Assalamu alaikum warahmatullah. This is part 4 of the lecture Rheumatoid Arthritis by Professor Dr. Abdelazeim elhefny. This is the intended learning outcomes if you can revise. Prognosis of rheumatoid arthritis patient. Because within the 3 years of onset, about 40% of rheumatoid arthritis patients are disabled, and within the 20 years, about 80% are moderately to severely disabled. So it is not a benign disease. It is a destructive and disabling one. In the past, about quarter of patients required a large joint replacement. So we have to treat this patient aggressively and monitor him meticulously. There are poor prognostic factors which we have to search for it, and if one or more of these factors are present, the patient are more prone to have a destructive and disabling disease more than others. That is persistent synovitis, involvement of metatarsophalangeal joints, increased clinical severity, that's to say more joints are inflamed every now and then, early erosive disease apparent in conventional radiology, and disability at presentation. Extra-articular findings, especially nodulosis, subcutaneous nodules, positive serum rheumatoid factor and anti-CCP in high titer, persistently elevated acute phase reactants like ESR and CRP, family history of rheumatoid arthritis, female gender, low socioeconomic factors and low level of education, advanced age, and smoking. The fate of this disease will be pain, destruction of the joints, loss of function, work disability, systemic disease, economic losses, and premature death. Now, what are the possible complications of this nearly malignant disease? It is not malignant, but we have to treat it aggressively like any malignant disease. Deformities, disabilities, and handicap, especially if the patient is left untreated or not detected and treated early. Muscle weakness, wasting, and atlantoaxial subluxation between cervical spine 1 and 2 during anesthesia and intubation. Henosynovitis, carpal tunnel syndrome causing compression of the median nerve, rupture of extensor tendons, Baker cyst, which cause swelling and pseudo-thrombophlebitis in the behind the knee with differential diagnosis of the DVT, secondary amyloidosis and focal glomerulonephritis, osteoporosis from the disease and from steroid use, rheumatoid vasculitis. This is one of the secondary cause of vasculitis and severe form in some cases, lymphatic obstruction and lymphoproliferative disorders, anemia, interstitial pulmonary disease and nodules, episcleritis and scleritis, and may cause perforation of the sclera in some cases, secondary Sjogren syndrome with dryness of the eye and mouth, pericarditis, myocarditis, ischemic heart disease, accelerated atherosclerosis. Mortality in RA may be due to cardiovascular disease. This is the most common cause of deaths in about 45% of patients with RA. Infection is the second most common cause of death, especially in the lung, skin, or joints. Malignancies like lymphoma and lung cancer or non-melanoma skin cancer. Now, how can we treat rheumatoid arthritis? The title is, our title to treat rheumatoid arthritis patients is Remission is Our Mission. Treatment of rheumatoid arthritis, treat to target. We have a target. The target of treatment are to obtain disease remission, or if not possible, at least low disease activity, and to maintain remission, and to prevent flares and complications like deformities and amyloidosis of the kidney, to treat any complication if occurred early and effectively. Early diagnosis and early referral to rheumatologist are essential for proper management. There is clinical window of opportunity for treating rheumatoid arthritis patients. The radiographic progression occurs early and continues over the lifetime of a patient. So, at the start of the disease onset, there is a very narrow critical window of opportunity in the early phase of the disease when we treat our patient properly in this time after early diagnosis and early referral to the specialist, which is the rheumatologist. We can prevent the complications and the suffer of our patient before the disease goes to the established phase and then spontaneously goes to the end stage with severe functional decline, radiographic damage, work disability, and premature death. The disease activity is our target because there is the inflammation of the joint, which is the sign and the cause of disease activity, will lead to joint damage, and this inflammation will lead to disability, and the joint damage also will lead to disability, and the disability will cause impaired quality of life and will increase the cost of the disease. So, for remission to be obtained, we have to attack and treat this inflammation and this activity, so it this dilemma will stop. There will be no joint damage, no disability, no impaired quality of life, and no further cost. Treat to target by the European League Against Rheumatism recommendations. If the patient has active rheumatoid arthritis, our main target is to think in remission. So we have to prescribe the drugs leading to remission, and we have to change to adapt the therapy according to measuring the disease activity to reach to the remission and to maintain this remission. If remission is not applicable, there is alternative target, which is low disease activity. Also, we have to adapt, change, and monitor therapy according to the disease activity to reach at least low disease activity, and then to sustain. If we reach it remission, we have to sustain this remission, and if we reach it low disease activity, we have to sustain this low disease activity by also adaptation of the therapy at any time if the state is lost. We have to assess to monitor the disease activity in the first few months every 1 to 3 months. And when we reach it to our target, we can elongate the frequency of reassessment to be every 3 to 6 months. We have to share our decision with our patient. Consider also comorbidities and other risk factors for the patient. Guidelines for rheumatoid arthritis management: early diagnosis and early referral and early treatment. First, the synthetic DMARDs, disease-modifying anti-rheumatic drugs, our weapons. The best of them is methotrexate, then leflunomide, sulfasalazine, hydroxychloroquine, and corticosteroid. The bridging stage therapy, because the previous drugs are somewhat slow of onset, so we have to give the patient bridging therapy for his pain and disability in the form of non-steroidal anti-inflammatory drugs and also corticosteroids. Biologic DMARDs, if the previous treatment failed, we have to give biologic disease-modifying anti-rheumatic drugs in the form of tumor necrosis factor blockers, targeting targeting T cells, or selective B cell depletion, or interleukin 6 inhibitor. Interleukin 1 inhibitor is now not effective, plus minus targeted synthetic disease-modifying anti-rheumatic drugs like tofacitinib. Combination therapy like methotrexate and biologic therapy are more effective. Types of treatment for rheumatoid arthritis nomenclature: disease-modifying anti-rheumatic drugs are either synthetic or biologic. Synthetic DMARDs are either conventional synthetic like methotrexate, sulfasalazine, leflunomide, or targeted synthetic disease-modifying like tofacitinib. Biologic disease-modifying anti-rheumatic drugs like biologic originators like tumor necrosis factor alpha inhibitors, or interleukin 1 or interleukin 6 inhibitors, or biosimilars. They are synthetic biologics, but of low price. This is the end of part 4, and we will soon deliver the last part of the lecture. And thank you.